Welcome to another of my topics in the series Surgery for Undergraduates. Today we will talk about pancreatic cancer. This is the diagram of the pancreas. As you can see here, the pancreas sits in the C-shaped segment of the duodenum, second and third part of the duodenum. It consists of two portions. The bulk of it is the exocrine portion, which secrete amylase, trypsin, and lipase, which are the digestive enzymes produced by the acinar cells of the pancreas. Scattered among this exocrine portion is the endocrine part of the gland known as the islets of Langerhans. Okay, as can be seen here, it consists of alpha cells will produce glucagon, which increase the blood glucose, beta cells which produce insulin that reduces the blood glucose. And surrounded that, as I said, are the exocrine acinas which produce the digestive enzymes, which are responsible for the digestion of carbohydrates, proteins, and fats. Closely related to its upper border are the splenic vessels, the splenic vein, and the splenic artery. And the tip of the pancreas is closely related to the hilum of the spleen. The digestive enzymes produced by the pancreatic acinar cells are secreted into the lobules and the fascillae, and finally they accumulate and drain into the main pancreatic duct, which is the backbone of the pancreas. These enzymes are then secreted into the second part of the duodenum as the digestive enzymes at the opening of the ampulla into the second part of the duodenum. The anatomy of the pancreas. The pancreas is a retroperitoneal organ which is located anterior to the second lumbar vertebra. The head of the pancreas consists of 30% of the total mass of the pancreas, whereas the body and tail comprises 70% of the mass of the pancreas. The pancreas weighs around 80 grams, and out of this, 80 to 90% is due to the exocrine acinar tissues. The exocrine tissues consist of a secretory and a system consisting of the ductules and acini, the intralobular ducts, the interlobular ducts, and the main pancreatic duct. Okay, this is the main pancreatic duct, which I mentioned just now. Then it is connected to all the intrapancreatic ducts. As I said, the endocrine portion consists of less than 20% of the tissues. Okay, they are mainly made up of A cells or alpha cells, beta cells, and delta cells. The alpha cells produce glucagon, which increases the blood sugar. The beta cells produces insulin, which reduces blood sugar. And the D cells or the delta cells secrete somatostatin, which cause increase in secretion of the exocrine glands. The exocrine portion, which consists of more than 80% of the gland, produces amylase, which is most widely used as a blood test for pancreatic damage, lipase, trypsin, elastase, and chymotrypsin. The physiology of the pancreas. The exocrine function of the pancreas is very simple. It stimulates the pancreatic secretion. In this respect, it is the stimulus of food from the duodenal, stimulates the secretion from the duodenal mucosa of secretin and cholecystokinin, which in turn increase the secretions from the pancreas. The vagus nerve increases the volume of these secretions from the pancreas. The pancreatic investigations. The usual pancreatic investigations are as follows. First, blood tests, serum amylase, lipase, and immunoglobulins. Urine test for serum urine amylase, trypsinogen 2, and urine diastase. And stool test, fecal fat content, and fecal elastase. The imaging techniques include ultrasound abdomen, computer tomography or CT scan, the MRCP, ERCP, endoscopic ultrasound or EUS, and lastly, the pancreatic function tests such as secretin stimulation tests. Next we come to carcinoma of the pancreas. Carcinoma of the pancreas or malignant tumors of the pancreas can be divided into endocrine and exocrine tumors. The endocrine tumors involving the islets, pancreatic islets, are extremely rare and we will not deal with it in this juncture. The exocrine gland carcinomas, the most common is ductal adenocarcinoma. In fact, 85% of the cases of pancreatic cancers belong to ductal adenocarcinoma, which mostly develop in the head of the pancreas. They are solid, serous, with dense fibrosis within the tumor. It is quite difficult, often, to differentiate this tumor from chronic pancreatitis. Pancreatic intraepithelial neoplasm or PAN-IN is an in situ pancreatic neoplasms within the ductal systems which are pre-malignant lesions. These tumors infiltrate locally along the nerve sheaths and the lymphatics and blood vessels. And they are also prone to produce liver and peritoneal metastases, which are rather common complications of this tumor. Then there are the cyst adenomas, are two types, serous cyst adenoma and mucinous cyst adenoma. Serous cyst adenomas are basically benign tumors, whereas mucinous cyst adenomas have a malignant potential. This is the complete classification by WHO on pancreatic exocrine tumors. And there are a number of tumors, malignant tumors of the pancreas, among which, as I said, the most common is ductal adenocarcinoma, which accounts for more than 85% of the cases. Risk factors for carcinoma of the pancreas. Age is an important factor. Usually it occurs in advanced age, above 65 years of age. Males are more affected. Smoking is a very important predisposing or risk factor. Family history, hereditary pancreatitis, and chronic pancreatitis are risk factors for the development of carcinoma of the pancreas. The less important ones are hereditary non-polyposis colorectal cancer, ataxia telangiectasia, Peutz-Jeghers syndrome, familial adiposis coli, and diabetes mellitus. The clinical presentation of carcinoma of the pancreas. There are two groups of such tumors. One is when the tumor involves the ampulla and the pancreatic head. These ampullary and pancreatic head tumors are usually painless with obstructive jaundice. Emphasize the word painless because despite their deep jaundice, the patients are relatively painless. They have pruritus, dark-colored urine, pale stools, and steatorrhea. Later, as the tumor increases in size, they develop nausea and especially epigastric discomfort, weight loss which can be very significant, hepatomegaly, and very importantly, enlarged gallbladder which becomes palpable. This is in keeping with the Courvoisier's law, which states that in a case of obstructive jaundice, enlarged gallbladder, obstruction is not due to stones. Most likely, it is due to carcinoma of the head of the pancreas, periampullary tumor, or cholangiocarcinoma. Okay, this diagram shows you the location of a carcinoma, the head of the pancreas, causing obstruction to the bile duct and the pancreatic duct. More so the bile duct, which causes deep jaundice and an enlarged gallbladder in these patients. The second group of tumors, which involve the body of the pancreas or the tail of the pancreas. So in these patients, the jaundice is not the main feature, but they have vague complaint of upper abdominal discomfort, anorexia, weight loss, and they may also have chronic backache, pain over the back, which is very severe, can be severe and not relieved by normal analgesics. They can have epigastric discomfort as the tumor grows in size, and the development of recent diabetes in patients, especially above 50 years old, 40 years old. They can have unexplained pancreatitis, and in advanced cases, they can present with enlarged Werkow's nose, ascites, abdominal or pelvic metastasis. Unexplained weight loss in patients with tumors of the body and tail of pancreas is another common presentation which must not be forgotten. Any patient with unexplained weight loss, a diagnosis of cancer pancreas must be considered. Investigations for carcinoma of the pancreas. If the patient comes with obstructive jaundice, suggesting the tumor is from the head of the pancreas, the urine and blood tests are done. And this respect, very important to do the liver function test to check for the level of bilirubin, conjugated, unconjugated, and the alpha alkaline phosphatase. Prothrombin time is very important, especially in these patients who are jaundice, and also a baseline level of the CA19-9 tumor marker. Ultrasound scan of the abdomen is important investigation, which will reveal a dilated biliary tree without stones. This is then followed by a contrast-enhanced CT scan of the abdomen, which will not only determine the size and location of the tumor, and also reveal the resectability and stage of the disease. If the tumor is resectable, then the investigations conclude there, and then the patient can proceed to definitive surgery. If the tumor is unresectable, then an ERCP is done with biliary stenting as necessary. In the third scenario, where tumor is not seen, then an ERCP with brush cytology or biopsy to detect if ampullary tumor is present. This can be done by a transduodenal or transgastric FNAFC under endoscopic ultrasound guidance to reveal the cause of the tumor, cause of the obstruction. Next, we come to staging of pancreatic cancer. Okay, the T staging is the TNM staging. The T staging is tumor T1 and T2 depending on the size of the tumor. Both are limited to within the pancreatic tissue, but is less or more than 2 centimeters in diameter. T3, when the adjacent structures are involved: infiltration into the duodenum, infiltration to the hilum of the spleen, infiltration into the kidney or suprarenal gland on the left side, and also infiltration into the splenic vein or the superior mesenteric vein and portal vein. T4, when the tumor infiltration into the superior mesenteric artery and infiltration into the celiac artery. What are the criteria for the to decide the resectability of the pancreatic tumor? Okay, in stage 1 and stage 4, there's no controversy. In stage 1, when the tumor is within the pancreas and the lymph node is negative and there are no second metastases, it is clearly an early cancer and that can be subjected to definitive surgery, so it's resectable. Stage 4, when the liver, peritoneum and lung metastases or other distant metastases are present, regardless of the T status or the N status, as long as it is M1, then this is unresectable. Okay, unresectable tumor, stage 4. In stage 2, is typically resectable, that is when it is T1 or T2 with N1 tumors, but M metastasis is negative, or it's a T3 tumor with N negative or N1, but no metastasis. So in these patients, it is resectable as long as the local involvement of the tumor does not cause extra pancreatic encasement of the celiac axis or the SMA. Okay, so as long as this celiac axis artery or the SMA is not encased in tumor, it is resectable. In stage 3, it is a T4 tumor. There is no lymph nodes may be negative or positive, metastasis negative. But as long as there's regional lymph nodes, the celiac axis lymph nodes, and the encasement of the celiac axis or the SMA with tumor, then it's considered unresectable. So the encasement of the celiac axis or the SMA by tumor is an important criteria to decide whether the tumor is resectable or not. Okay, treatment of carcinoma of the pancreas. Unfortunately, 85% of patients, the tumors are unresectable at the time of diagnosis. When it is diagnosed as in early pancreatic cancer, there are two types of operations. One original operation is known as the Whipple's operation, okay, which we will describe in a short while, which removes the gastric antrum. And second is the Pylorus-Preserving, which is a modified of Whipple's operation, a Pylorus-Preserving Pancreato-Duodenectomy, okay, with local lymphadenectomy. For tumors in the body or tail of the pancreas, distal pancreatectomy, a lesser procedure, is usually undertaken. Okay, this is the Whipple's Pancreato-Duodenectomy. This is before the operation. The purple colored regions are the areas that are removed, resected and removed, which include the gallbladder, the common bile duct, the antrum of the stomach, and the whole duodenum. Okay, all first, second, third and fourth part of the duodenum, whole of the duodenum is removed and blocked. And this is then there's a triple reconstruction by doing a triple bypass. Okay, a single loop of jejunum is anastomosed to the common hepatic duct, choledochoduodenostomy. Then you have got your pancreatic stump, okay, the body of the pancreas, anastomosed to the side of the jejunum, known as the pancreatico-duodenostomy. And the third bypass is known as between the jejunum and the stomach, and that is known as gastrojejunostomy. Okay, so in these patients, you establish direct communication between the stomach and the jejunum, and this is a fistula created, commonly causes jejunal-gastric reflux and a lot of post-operative complications. Okay, so this is a Whipple's triple operation, triple bypass operation: choledochojejunostomy, pancreaticojejunostomy, and gastrojejunostomy. This is the modified Whipple's operation, the Pylorus-Preserving Pancreato-Duodenectomy. Okay, PPPD. Okay, it is same, almost similar operation, except that the pylorus of the stomach is preserved to prevent this jejunal gastric reflux. Okay, pylorus is preserved. The other operations are all similar. Okay, so this is your first bypass. It is your end-to-end hepatojejunostomy or choledochojejunostomy, side-to-side duodenojejunostomy. No more gastrojejunostomy, is duodenal-gastrostomy. And then the pancreaticojejunostomy, as usual, which I said, the third one. Okay, so the three bypasses are still there, except in this case, the pylorus is preserved, thereby the reflux of jejunal contents into the stomach is reduced by the presence of the pyloic sphincter. Prognosis of carcinoma of the pancreas. Only 15% of tumors are resectable. Okay, this is an important fact to note. And after even this 15% of the tumors that are resectable, you subject them to operation, Whipple's or a PPPD. Post-operative mortality for this major operative procedure is 30 to 40% due to bleeding, infection, leakage from anastomosis between the pancreas and the bowel. Okay, morbidity 30 to 40%. Post-operative mortality 3 to 5%, and in some centers which is more than 5%. Overall 5-year survival rate after this operation is 7 to 25%. Okay, in many centers they do not reach this 25%. It's much lower than 25%. Whereas if it is an ampullary tumor, total resection will give you 40% 5-year survival rate. So the prognosis of periampullary tumor is much better than carcinoma head of pancreas. In carcinoma head of pancreas, who's undergoing this operation, the post-resected mean survival is 10 to 20 months. So most of the patients die within 2 years, even after a curative operation. In unresectable tumors, okay, 85% of them were unresectable. The tumors are locally advanced, okay, or they may be metastatic, okay, even metastatic, and the mean survival is 6 to 10%. And if there's metastatic disease, it's 2 to 6 months survival rate. So in either way, the prognosis is not very favorable in both cases. Then we come to those patients these patients who are unresectable, come to adjuvant treatment. Adjuvant treatment in the form of chemotherapy, palliative treatment with 5-fluorouracil or gemcitabine are common drugs that are used, and despite their use, the prognosis is not very favorable. Unlike if it is lymphoma, then it is slightly better. So in these patients, palliative treatment for unresectable tumor is very important in these patients to improve their quality of life. If it is done during surgery, during laparotomy it is found to be unresectable, then the CBD obstruction can be relieved by a choledochoduodenostomy or choledochoduodenostomy. If these are not possible, then a simpler procedure, cholecystoduodenostomy, could be done to divert or decompress the bile ducts. If the duodenum is obstructed and the patient has difficulty in feeding because of the obstruction and vomiting, then a gastroduodenostomy may ease the patient's symptoms. If the patient has massive or gross steatorrhea, then you may have to treat him with enzyme supplements. Diabetes mellitus usually has to be treated with insulin in these cases. And in advanced cases, pain is a very important symptom. So these patients should be given adequate analgesics, opiate analgesics, or even referred to pain clinics for nerve blocks and treatment and other forms of treatment to control pain. Okay, let's say if it is not during the operation, it is done, then endoscopic procedures can be done. Endoscopic stents, doing an ARCP, plastic stents, or expandable metal or mesh stents can be placed, which can be placed either endoscopically or percutaneously. Okay, these diagrams show you this is a percutaneous approach of placing a stent into the bile duct to relieve the obstruction of the bile ducts. As a result, the jaundice is relieved and the patient feels much comfortable after the procedure. This is done through an endoscope. Okay, the stent placed in the lower end of the common bile duct to reduce the blockage or obstruction, relieve the obstruction of the bile duct. As a result, the jaundice comes down, patient feels better. And if the duodenum is obstructed but tumor infiltrating into it, to relieve that, endoscopic stent can also be placed through the stomach and into the duodenum. These stents are nowadays very thin and they expand spontaneously after being placed for some time, thereby allowing food to bypass and allowing the patient to feel much better. What are the surgery that is in summary, what is the surgery that is available in pancreatic cancers? If it is resectable, it's either a Whipple's operation or Pylorus-Preserving Pancreato-Duodenectomy. Okay, either one. Nowadays, most people preserve the second. If it is unresectable, then depends on where the tumor is obstructing. If it is a CBD obstruction, which is the more common obstruction, with resultant severe jaundice, then ERCP stenting can be done. Okay, or open choledochoduodenostomy, choledochoduodenostomy, or cholecystoduodenostomy. These three procedures can be done either open surgery or laparoscopically. If the duodenum is obstructed, which is less common, then endoscopic stenting is the treatment of choice, as I mentioned just now. Failing which, you can do a gastroduodenostomy, thereby bypassing the duodenum. Talk on pancreatic cancer will be of great help to you in understanding the topic better. Since I meet you again in another topic, thank you.